All right, welcome everyone. We got documentation dismemberment. We're going to be doing an urgent care note today. So disclosures, we have none. Got a lot of prayers going up, hoping that it wasn't their urgent care note. Objectives, same as usual, just reviewing the 2021, 2023 coding guidelines and how that impacts our documentation. No specific requirements for history review of systems or physical exam, so long as you document what all is necessary to take care of the patient. So then jumping right into this case with the HPI. So just take a couple minutes and read through this and I mean, it's too easy for me yesterday, sorry. I knew you'd have your notes.
Not good notes, but they're done.
Any questions or comments on the HPI?
Complete.
Yeah, so I think overall, it's a short and sweet HPI. Documented everything I think there is to document on what seems to be a fairly straightforward case. You know, I think and an important thing in urgent care too, documenting what the patient has already tried. That's not something in there. Most of our outpatient chronic notes, not something you're really having to do, but with these acute visits, just capturing what they've already done. And from a documentation standpoint, it's nice. From a coding standpoint, it doesn't help you so much, but always good to at least get that in there. Any way it could have been shorter, need to be shorter? Any thoughts on length?
This is my last room.
Seems good to me.
Yeah, I mean, I think it's one of those where just looking at the chief complaint, this is such a low acuity presentation. You could almost make this almost nothing of an HPI because you don't need that much information. I think it's a really good HPI, but if you really were trying to see 180 a day, you could probably trim this down to one sentence. All right, so moving on to the histories. The 16-year-old, not a lot of history there. Any questions about that? All right, so review of systems physical exam.
Doesn't have a fever. Throat complaint, maybe a throat exam. Or is it just cough?
No, that's sore throat.
Sore throat. Left the T off the HENT. The hen exam.
I did look in her ear later.
I think that's the HEN.
You see if that tube was still there.
So this is where you, I mean, getting into how much physical exam really even needs to be done on this case. Probably not much, but you know, with a sore throat, like getting a throat exam would be better than abdomen and MSK. I think this gets into, do you build an auto tag specifically for a URI exam so that it automatically just drops off a bunch of that other stuff? I think we get in the habit of using the same dot phrase for all these physical exams. And then you either have to spend time trimming out whole sections. I mean, you could trim half this exam out if you wanted to get it down to really what was the exam you would perform for this case.
I think I have one. I just forgot what I named it.
Also, one of the keys of naming stuff is getting a naming convention that makes sense and you can remember. I've changed all mine to URI something, like URI differential, URI exam,
I just need to steal it.
URI instructions, URI.
History.
Why not? I mean, you really could do
Change
it.
the dates.
You really could do a URI history and use drop downs.
Drop downs, yeah. Actually, I have that. I have one. I can drop down, just fix it.
And instead of actually dictating it, I mean, these are the things I'm thinking about doing because I haven't done the history yet, but it's next on the list. Because it's the same things over and
You
over.
want to cover the same things.
Right.
That way they're all uniform and you know you're not missing something. Sometimes I forget to ask the same things because you do it 180 times.
Yeah, so I think just, in an urgent care setting, you don't want to get too specific with your auto text because then you'll forget what they are. But finding the top 2 or 3 things and just knowing that's what it is. It's honestly, I call all mine URI, no matter based off chief complaint. Like it doesn't matter what they come in with. They're all getting a URI, HPI, and exam because it's differential because they're all cough, sore throat, something. So even if it doesn't turn out to be an actual just viral URI, it doesn't matter. But that's easy to remember.
I break that down as well.
I've got a URI. Yeah, I mean, because you're going to tell them to do
Same.
the same things. So moving into assessment and plan. Any questions or comments on assessment and plan?
Probably don't need to put that the swabs were negative in the assessment and plan if I already put it in the MDM.
Yeah.
Or that person who wrote the note.
How much of it did, like in your MDM, do you use like that first line there, like they're presenting? I think you usually probably put a differential, start with that line, differential diagnosis includes,
Right.
because you already talked about her complaints and everything.
Yeah, I mean, to me, the differential diagnosis includes
Right.
sentence is the only piece in that paragraph that really added.
Yeah.
Because you could pick up differential diagnoses from that list to add to your problems, and we're gonna get into that a little more later on. Having the COVID strep flu negative makes sense in there somewhere, but as stated twice, doesn't really help.
I was just thinking people that go back and look at these notes if they come in a week and still have these symptoms, they're probably not going to read my MDM, but they'll probably read my assessment plan. So
Right.
people should probably put more in the assessment plan, maybe the results out When
I really like your assessment plan, or whoever's.
Yeah, whoever.
I think I'm probably guilty of not putting in the assessment plan. I put all the MDM and move on. That's what you had discussion about. I told her to take this and this and this.
I just know people usually probably never.
Right,
go
I
back
know
and-
that's a thing.
I
but-
mentioned
I
at the
put almost
time,
everything down in my assessment and plan, and then my MDM is usually just see below because I've already written it out
It's
down
honestly
below.
copy and paste. I just highlight.
Right.
But I mean, because what's in the MDM there, it looks more, almost more like patient instructions.
Mhm.
Yes,
That's it.
which, I mean, if you are copying and pasting between your MDM and your patient instructions, you're killing two birds with one stone.
Because if you
It's-
take the Tylenol down to water Pedialyte, you can copy and paste that and put in instruction. It's perfect.
Right.
Yeah. Or actually, all the way down to school at this time, because that tells them how to eat, Tylenol, hydration, and can go back to school since she's, afebrile. Hopefully, mom knows that. But
Now, does this spelling it out get you more credit versus saying symptomatic treatment discussed with mom and daughter for viral URI? No, putting it into the instructions.
That should been-
Y'all know that putting it in the AMP gets you anything extra.
Because it's all lifestyle conservative stuff, so it's all low level. So no, you're not getting any credit for any of this stuff.
because technically, even though you prescribed it, everything I did was over the
It's
counter.
over the counter stuff.
Grocery store.
So now what I've found is you can actually program copy and paste on your Dragon,
Yeah.
on your mic, on the speech mic.
Yeah.
Or do you do it verbally or do you use the buttons?
Well, F1, F2, and
Yeah.
F4, if you know, is bold. 4 is bold.
That's how you bold
That's
fast.
how I bold fast.
Know this.
I'm
Yeah.
very efficient with my notes.
I like the honey, honey, like how much store has needed.
Well, that's usually their biggest complaint. I'm like, what do you want me to do with your paragitis?
He's 16 years old.
Using
Goes in-
Dragon commands, Dragon commands are the key to the efficiency.
So
Whether it's on your keyboard or the actual speech mic itself,
see, the
you
problem
can
is,
program different buttons.
I don't know if it happens to you, but the physician counter at urgent care, that Dragon, I don't know who talked to it, but it does not understand anything.
It does
It
not.
does not
listen- it does not
understand.
listen.
It makes so many mistakes, it's unbearable.
It's like
I
a
just use my
marriage.
phone. Yeah,
I'm trained. I'm trained.
It's talking fish are changes, but
It's better than it used to be. It used to not even work.
yeah, like I said, used to not work. But I just use my phone. 'Cause my phone, at least, the only person that's talked to that one is me. And so the only problem is you don't have buttons.
Yeah, it's super sensitive, that one. It will pick up anybody that's sitting on that line. And you can't, it's getting so much, I think it doesn't listen well because it's hearing all this other stuff.
Yeah.
It doesn't work.
Yeah, sensitivities.
You would think you could dial up and down sensitivities, to how loud you have to speak, how close it was catching, but I've never found that feature.
Okay.
Yeah, no, to me, I like the assessment plan, just very short bullet points of what. I honestly don't even get that. I don't get that clear with it in my assessment plan. I usually do a conservative measures only, no antibiotics indicated this time. Done. And because all that other stuff's gonna be in the patient instructions, because it doesn't get you any credit here, it's really for the patients. Doesn't make it wrong to put it in here, it's just if you're looking at how to shave time.
Dutch phrase.
I was gonna say that literally right there.
Just
The
talking
dot
about-
phrase for me would be money.
All right, so patients trying, it was just the prescriptions, just to highlight that those two prescriptions were sent. Diagnostic results,
Would be real weird.
and see, I get into this too, is like, just putting swabs negative in there mean anything if
Because
your
it's in
note
there.
already has all of your results in.
It for me, it's personally again. If when I go back and look at if I've seen they've been seen, I can look at the assessment and plan
Yes.
instead of going all the way down to labs and instructions and stuff. If and I know people don't have all the time in the world to do notes like other providers because they're seeing more, but I don't know.
I think I usually put swabs negative in there too. I don't outline exactly which ones. they
Because
were
sometimes
usually.
in the note actually, it will have previous results too. So then it's just kind of
Yes, I cut that off.
Yeah, it gets messy sometimes. Because then you're like, which one was negative? If they have a positive in there, you have to make sure you have the date. I don't know.
I just put them in. It's dictation.
All right, so medical decision making, sort of by the guidelines. All your coding is based on the MDM, which is the 3 categories of diagnoses, data, and risk. Each component gets assigned a level, but the final MDM is the highest 2 out of the 3, which comes into play in this note. So there's just a quick example. So moving into just a breakdown of definitions of diagnoses, which are also known as the COPA. If you ever hear that term, that will be conditions. I forget exactly what COPA stands for off the top of my head, to be honest, but basically the diagnoses. So in an urgent care setting, it's probably one of the more dynamic settings you're in, having to try to remember a 3 versus a 4 versus a 5. Because on the inpatient side, you're pretty much playing 4 versus 5. In the ED, you're almost always 4 versus 5. In the clinic, you're 3 versus 4. But in urgent care, you really get the biggest mix of 3, 4s, and 5s out of probably any situation.
No twos.
No, not really any 2s. There are probably some 2s that come through, but if you're building out as a 2, you've failed this course.
Complexity of problems addressed.
There you go. Complexity.
Mine just kept saying COPD? Question mark.
Doesn't diagnosis sound much better than complexity of problems addressed? Nobody can remember what that is. That's CMS for you. So really, you have to remember it all if you're really trying to be better at urgent care, because you really need to know, to have but so much of what comes in there is a self-limited or minor problem. The thing is, it takes 2 or more self-limited or minor problems to get low. That's the catch that you have to think about in the urgent care.
Would this one be one acute illness with systemic symptoms?
Probably, systemic symptoms, probably, no, they're not short of breath, they're not.
I mean, I would say
It's
3.
stress.
One is stable acute.
This would be a 3.
So then you really have to get into the weeds of definitions as to what those mean. So what a self-limited or minor problem is a problem that runs a definite and prescribed course and not likely to permanently alter health status.
Unless it was straight.
Yeah.
Unless it was strep. Then you could probably,
Every time you
Yeah,
run a
but that
stress
doesn't
ball,
go with diagnosis, though, that'd be it.
but you're ruling it out. You talk about it.
so the difference, so that gets into the differential
That's
thing.
the
We
other
gotta-
piece. We gotta do the whole medical management though. Anyways,
Anyway, so then you get into acute, so to me, self-limited or minor versus acute uncomplicated is really splitting hairs. But that gets into how you document the patient gets into how this gets coded out. Now, this is so subjective to the coder, because a recent or new short-term problem with low risk of morbidity for which treatment is considered with little to no risk of mortality with treatment. So by even recommending OTC meds, does that elevate from a self-limited minor problem to an acute uncomplicated illness? It's a great question for coding that I think is one thing to ask, but once again, you could probably get a different answer. No matter how many, you ask 10 coders, you may get 10 answers.
But because all swabs are negative, you probably could get an undiagnosed new problem with uncertain prognosis. Could be the bird flu. It could be anything out there.
if we had a throat exam.
I mean,
I think you would really have to play it up for that. You would have to put some crazy diagnosis on it, because as soon as you call it a viral URI, you've given it a self-limited minor. If you put possibly bird flu, Like you would have to go out of your way to escalate that as its own ICD-10 code. Because it's, no coder's ever gonna look at that and go, well, let's crank that up. No, those people are more afraid of fraud than your account. All right, so from a diagnosis standpoint, we got viral URI. 3.
Right.
Yeah, so that's I mean, I think we've got to talk through viral URI unless you've specified something down here is a self-limit or a minor problem. Yeah, I think you could go so far as, I mean, there are people who test negative for the flu that really sound like they've got the flu. If they've got myalgias and they got fevers and they've got more systemic type symptoms, you're still not going to get the systemic symptoms with that. But you could at least get to, there's something more, I suspect this is flu that is testing negative. Well, influenza carries more than a self-limited or minor problem, and people die from the flu. So I think that could get you to that acute uncomplicated territory. But you would have to put in a statement, I suspect this is flu, but I can't call it that because I got a negative test. I do think you could, that was the thing you could probably upgrade this into. If that was the case, based on the symptoms in the presentation, I don't think so. Similarly, so what about sore throat? Self-limit. So how could you trump sore throat up into something else?
He said he suspected to be strep.
If you suspect it to be strep in light of a negative test and you send it to
Send
culture,
yeah.
then suddenly you've escalated sore throat to an acute uncomplicated because strep throat has greater risk of complications with it. So yeah, so it all gets into, what do you think? I mean, if you're documenting what you're thinking, you're going to get credit for it. I don't know that there was a lot of thought that needed to go into this case. So I don't think you could really play that up in this one. But what else is in here that actually could elevate the diagnosis of this? We kind of already talked about it.
What else is in his note?
Yeah, they can count because it's in there. Factors different, so all differential diagnoses considered count as problems.
Right.
Now, whether you need to rule them out, you could get a coder who's a little stricter on that, or you just set it up here, but you never really rule it out. But obviously, influenza and strep are, to me, acute uncomplicated. So because they're in the differential, you've got 2 tests ruling them out. I feel like those by themselves actually get you the acute uncomplicated and make this a pure level 3. And because otherwise you're hoping that you're going to get credit for 2 self-limited minors off of viral URI and sore throat. I think they would give you the 2 self-limited or minors because you've documented 2 problems and you've done it. But what if you just put viral URI on this thing? See, if you don't put sore throat on there, this could get kicked down to 2.
I try to be better about putting more diagnosis that they
With
have.
your
But
assessment
this is
plan-
why team health really wants people to put differential diagnoses. Because you're automatically putting things on there that have at least 2 self-limited or minors in your differential.
Now, if he just had the viral URI and in the assessment plan wrote pneumonia ruled out, secondary physical exam. That would have kicked it up.
That kicks it up for sure, but that takes a lot of extra effort. Whereas to me,
That needs to be in your dot phrase.
I mean,
listen to them. You're gonna listen to everybody's coughing.
right. Yes, you can put that in your, I mean, yeah, you could create that in your auto text. You don't want to be dictating that every time.
No, I agree. We don't get to everything.
So yeah, the differential diagnosis section becomes important for these acute low acuity acute visits because they get your two self-limited or minors or get you an option and an acute uncomplicated differential that you're generally ruling out in the flow of this that keeps you from getting down coded. So we've kind of talked through what this is going to be from a diagnosis level. It's a level 3 on either the two self-limited problems that are documented or using the differential to get to me, pneumonia, because it's never really addressed anywhere else, is one of those that I think most coders are probably going to not give you credit for that you really did anything with it. But obviously the COVID, the flu, the strep all got tested for. So
Like
those,
if you say like examination looks okay, lungs clear, and viral is negative, so I would like expecting low in my differential pneumonia. Does that count to you?
yeah, if you have anything else in there past the just differential list of differentials, that's going to get it as far.
Right.
Well, I think in most of these cases, unless you're going down the road of getting a chest x-ray, is it worth making sure you get that in your note? If it's in an auto text somewhere and you're doing that every time you're seeing these patients. If you can fit that in an auto text that you're comfortable with, then leave it in there, but. We've already talked through all the scenarios that could get us to a higher level. Maybe not. So, you know, of course, we talked through if this was a positive COVID, flu, or strep, obviously we talked about how flu or strep would definitely be the acute. Does that get you to can that get you to a level 4?
Get man body.
But as a diagnosis,
You know, because I don't know if it would be self-limited.
well, it's an acute uncomplicated.
So,
So you're still even with strep, I think you're in an acute uncomplicated illness.
new problem with uncertain prognosis, they're going to get that post-strep from glomerulitis. So,
Yeah, I think the only thing that could get you to a 4 is if you had an acute illness with systemic symptoms. So if you read that, then you look at the actual definition, high risk of morbidity without treatment.
Isn't that
So-
strep though? I mean, the whole problem is with strep is if you don't treat it, the heart complications.
Right, but who? Yeah, younger children,
Wait,
not a 16-year-old. So that's where so does a coder even know that? So if you're looking at this from a coder standpoint, they're not even gonna be thinking that. So that's where if you're seeing a 5-year-old and you're going to document that you're treating them anyway for strep. So when you include that in there, you just need to make sure that your documentation of why you treated them empirically or you got a throat culture because of this risk of complications in that age group. Now suddenly you have made that a bigger problem. And it's going to be obvious to a coder. But you know, you're not going to get away with that 16-year-old who honestly strep is, is there a risk for peritonsillar abscesses and things like that? Yes. Is it a high risk? No, I don't think you could make the argument that it's it would be hard to make the argument that any of it's high risk because how much strep goes untreated and they don't get.
You should just throw tuberculosis in your MDM. Just put no exposure in your.
Then we'd have all admitted for
For
serial AFP smear. 333. All right, so what if, it's a 16-year-old, but what problems could a 16-year-old have? That if you see the asthma, so you're gonna pull asthma in. If they ever had any chronic lung issues, if they're, Down syndrome, if there are any kind of congenital genetic things wrong. in a 16-year-old, like, those are the things you pull in. You know, is morbid obese. I mean, now we're dealing with 16-year-olds that are morbidly obese. I mean, I think thinking about pulling in these other diagnoses can then actually help escalate you up, potentially to get to a 4. Because now you're having to deal with a chronic, now you pull a chronic illness into this mix. All right, so moving into data. And once again, I mean, mostly urgent care is going to live in the 3 versus 4. But at the end of the day, if you can remember all the categories for a level 4, it's the same as a level 5. And if you're always thinking about how to get a level 4, then you're easily going to get a level 3. You know, just remembering that category 1 are all your test documents and a historian. Category 2 is the independent interpretation of tests. And then category 3 is the discussion with an external provider. So, you know, review of external notes. It's an interesting question. I think you wouldn't get credit, but reviewing a prior urgent care note is almost like in clinic. You're reviewing same clinic, same specialty, so you're probably not going to get credit for it.
But
It seems different, it feels different, but I think it's a,
It will be different when with different problems. Say chest pain, and they were cardiology a week ago.
well, cardiology, different specialty. Anytime you review the note of a different
Specialist,
specialty,
then it's counted.
then that counts for your category 1.
if you had somebody an urgent care the second time for a UTI, you look at that sensitivities to prescribe antibiotics, you're not gonna get any credit for that.
That's a
That's
review of
unique
results.
text.
The
It's a
result.
unique test result.
It's
So
very
as
true.
long as you document what you like that you reviewed a urine culture and this is what showed, but you'll have to explicitly say, you know, looked at urine culture from
Yeah.
January
But you
10th.
have to look at the document, see if it's someone around antibiotic, you gonna look at the document too.
Right. But if it's from urgent care, it's the same as clinic. Like if you look back at somebody else's clinic notes, you're not gonna get credit for it. Because you're in the same practice at the same specialty.
So if you order 3 unique tests, does that get the category 1?
Yes,
What you got?
if you order them or review them, and they don't count double.
Mhm.
So like review, if you ordered it and reviewed it in the same visit, it just counts for 1. You actually can't get double credit no matter how you do it. If you've ordered the test, wherever that, like you counted for that, you technically aren't supposed to get credit 3 months later when you follow up and review the result. Because you ordered, like you're responsible for that whole order and the entirety of that.
You're just assuming you're gonna review it.
Yes, it's
They pay you
implied
for
that
it.
when I ordered it, I'm actually going to take care of it. So
Is
you
it
can,
just like radiology with the independent interpretation of tests?
so independent interpretation only applies to tests that need interpretation is defined by what it requires to interpret something, not just
Reading results?
review yeah.
You can't say, I looked at the swab and like, I seen a faint line.
If you read the chest X-ray,
Yeah, it has to be something that has a separate billable charge for interpreting. So in the coding world, interpretation is tied to a CPT code to charge for that interpretation. So that's what they mean when they say independent interpretation. Doesn't mean you actually bill for it. You actually can't bill for it and get category 2 credit. You have to look at it yourself and document it, but not bill for the interpretation, which will be all radiology because you aren't licensed or privileged to do that. EKGs is where it gets tricky because you actually will have privileges. And in the urgent care, you do your own EKG interpretation and bill for it separately. So it does not count as any of your category credit towards data because you've already billed for it separately. So really nothing exciting from a data standpoint. It looks pretty simple, but how many what do we have in category 1 here?
it's got 3.
We got 3.
It's got 3.
Interpret.
I mean,
Does it count the flu A and B?
I was gonna say, technically, you've got 4.
Cause you got
So it's a single order.
One test.
So yeah, it's all about how it's ordered. Because to me, like the combos we do in clinic, it's really that's one of these splitting hairs. It's gonna be, how does your coder look at it? Because technically you only ordered one swab, but you got two separate results. I suppose somebody might argue this is 4. I think generally you're gonna say it's 3. I mean, conservative.
Oh, they know.
Most coders are going to be conservative and say you ordered 3 orders, you got 3 results.
Well, like,
You understand? It's like a CBC. You get one CBC is all components.
now on that note, like let's say I had a patient in who were screening for hepatitis or something, and there's inserter here, all of the different surface antigens, antibodies, core antigens for all of these different things you can order, or you can order the Hep B panel and it pulls them from the full panel. So if you ordered all of those tests separately rather than through the panel, are you able to bill for more there?
Yes.
That feels strange.
Listen, you got
Welcome to healthcare.
Yeah, welcome to
I can
healthcare.
acknowledge
Welcome to
that-
government
That's
regulation.
the way things work. That just feels odd.
Welcome to insurance companies.
So it,
It's all about, I mean, it's a unique test, so it's unique to that CPT code. But it all comes back to how it's all built out on the ends. You ordered one order which had one. Now, some of those may have multiple CPT codes in the background for each test, or it may bill out as one lump charge. How are you ever gonna know? You don't. Probably it bills them out individually, but I couldn't tell you if it did. And it's not worth your time to try to figure it out, so. Yeah, is there some gray area that we may never know? Yes. Like, how many licks does it take to get to the center of the Tootsie Pop? So we're gonna go with 3 on this. How many category 2? 0, because we didn't interpret anything. Category 3, we didn't talk to anybody, so it's a 0. So MDM data level for this,
3. That was a 4, right? Or no, you have to have 1.
If you have 3 independent tests, that means that
this is at least 3 independent tests.
so that makes it a,
to get a 4, you have to have 2 of them. Don't you?
that's a 5.
Oh, that's a 5. Sorry, so then 4.
Yeah, so this is a 4. Because to get a 3, you have to have 2.
That's right.
Yeah, so level 3 is just 2 of the category 1s. And then a level 4 is 3 category 1s, or a category 2, or a category 3. Level 5, you have to have 2 of the categories. Like to get a 5 here, you would have had to have been done how could this be a level 5?
Contact ID. I'm sure that they're.
Yes, call infectious disease.
Order a chest X-ray. Make sure it won't pneumonia.
Yeah, I mean, a chest X-ray, if you suspected pneumonia on this, then you get a chest X-ray, you do your independent interpretation, but you have to do your independent interpretation or to get it on the data side. So, but if you order all the chest X-rays all day long, but if you don't document that you reviewed the images and this is your interpretation, you're not gonna get credit for it, whether you did or you didn't. You won't get credit. You only get category 1 credit for ordering. Yeah, I mean, a chest X-ray, you get a chest X-ray, you're a gold level 4.
We talked about like all the dot phrases and everything. Do the providers get credit when they say all tests independently ordered and interpreted by me,
No,
discussed with patient,
Specific.
and doesn't say anything else?
I mean, generic documentations
Asking to be.
almost always useless. Because if you're the coder looking at this going, how did this impact the medical decision making? And it's like, okay, you did your job. You reviewed the test and you talked to the patient about it. Like, that's not medical decision. I mean, it's not really medical decision making. And so, no, you're not gonna get credit for that. And most of what they're saying they reviewed are labs that you really don't, like if you ordered them, you already had credit for it, whether you reviewed them or not. So it doesn't help you. And a blanket statement, you actually have to, you actually have to document what you saw in the images. Because you have to make an attempt at an interpretation. And so an interpretation, as required to bill for it, requires you look at certain elements of a chest X. I mean, you have to have, and you can't just say negative. Like you really need some specifics. You have to pretend to talk like a radiologist.
Clinical correlation.
Without the clinical correlation recommended parts. That's what you're supposed to be doing. But, you know, just making a comment on, there's no infiltrates, there's no pulmonary edema, there's no effusions. There's no bony abnormalities. I mean, just, you have to get in the habit of saying just kind of those snippets that you're gonna see in most chest x-ray reads.
Go through your ABCD. ED.
So you can't just say no, acute cardiopulmonary process identified.
Yeah, see, that's not, the impression is not what actually gets him credit for the
It's the
interpretation.
Is that
It's-
paragraph
it's-
above
It's
it?
all that stuff
It's that
above
above
it,
it.
the billing
Yeah.
part, but the details. The
Yeah.
impression is just for us to quickly look at it and know what they thought was important. It doesn't actually help them from a billing standpoint.
Right.
But if that's all you use as your interpretation, it doesn't really,
Mhm.
you're probably not gonna get credit.
My interpretation of their impression. Normal X-ray.
Concur.
And there's nothing saying that you can't be looking at their stuff, looking at it, correlating the two. I wouldn't read it all verbatim. Probably not gonna go well. You get audited. Bolded.
That's the key.
You get audited on that. There'll be nobody to defend you. I mean, the interpretation required is at the level of what you're capable of doing. And nobody's expecting you to generate a perfect X-ray interpretation. Just like, what were you looking for in your clinical correlation? Like, I was looking for pneumonia. There's no pneumonia there. There's no pulmonary edema. I love to say trachea is midline in my best X-ray interpretations because you're usually looking at it, so gotta count for something. So now moving into the risk section. Risk gets a little more complicated in a urgent care, I think, because you got a lot more, you're gonna more frequently be ordering imaging. In clinic, we mostly focus on prescription drug management. If you can prescribe a drug, then you got your 4 and you're moving on.
But when you do their med rec, discharge, you're telling them what to continue or not. Cause don't we always do, I mean, I've been doing the med recs over there.
Yes,
Yeah. I've been doing it, I know we didn't have to, cause if you tell them they could,
I mean, you cannot discharge them without.
right, so if you do their med rec, I mean, hers won't be nothing but anybody else who had lisinopril. A beta blocker,
You have
you don't
to, you have to
continue.
look it up.
well, that, so then how do you have, yes, but it has to be in the notes that actually addressed.
Okay. So even though they were sick, continue ACE and oral intake.
Right, if you wanna waste time putting hypertension as a problem and saying continue blood pressure medications per med reg, yeah, you can get credit for it.
Remember your.
See that? Note for the PCP to change the SNR, like depression medication, they are like 2-3 medicine there. Like put their like recommendation, probably put it again.
Why, if you're actually putting in your assessment plan and addressing it, then you're gonna get credit for it.
Right.
But just doing the med reg, you're not really addressing anywhere else in the note to show that you actually really made any.
Why we gotta do it? I don't get any credit for looking at this guy's medicines. Why don't I look at them? If I just look at it from a superficial standpoint, and say, you don't have COVID, you don't have strength.
Well, you're not just hitting acknowledge at all or sign if you didn't want to get rid of it.
You have to
Yeah, that's what
click
he's saying.
on it.
Why does he need to put the green check mark if he's not changing anything?
Well, that's why you hit the acknowledge button and you sign it and move on. Cause you didn't actually look at it. Like line by line, continuing stuff.
But what Austin's saying is, why do I even have to hit the?
Why you have to do it?
Yeah.
Just cause it's best practice. I mean, it's just
Well,
one.
I
that's
mean,
a
I
patient-
understand, but if I'm gonna be held accountable for it,
You ought to get credit for
you
it.
know, I get credit for it. Cause let's just say she's a little bit hypotensive and I say continue your ACE. Or did, and then they go home and pass out, they come back, they're gonna look back at me,
Yeah,
it will. So I mean,
but if they were hypotensive, you probably would have addressed the
hopefully,
note.
And then that would go
Or told them
under
to hold it or
prescription drug
stop.
management.
it's like prescription drug management would be the med rec.
But med recs are done by non-LIPs as well, so.
But only the med rec of it, not the discharge.
Like the
one,
med
though.
history though.
Right.
Just and sometimes they do.
I mean, that's, to me, it's kind of surprising that you don't get a 4 for every time you, unless it's somebody like this one who don't have any meds, there's nothing to read. So there's no
I
prescription.
mean, I'm sure you can make the argument with the codes.
I mean, I didn't know what the normal was.
I can't.
I thought that's
see-
why we always done it, just because it helps you do prescription drug management for everybody.
Kim always says it's for something else though.
But you didn't
I thought
prescribe
it was patient
anything.
safety.
But if you're not even prescribing it though, then you get credit. Like you're just telling them to keep,
You're still
Oh.
having to review it.
yeah, I just don't think you get credit for it.
That's enough, that's fine.
So scrap.
I've never read another one.
What you do now?
Word.
I mean, at the end of the day, like if you're really spending time going through that, changing stuff around, that's why they're gonna pay you more. But if you kind of glanced at it and hit the acknowledge all, and hit sign, you're responsible for it no matter what
Right,
what
right.
buttons you click. But did you really do any work to get paid extra?
Clicking
For clicking 3 buttons?
Yeah.
so much. Clicking.
Are you responsible for it if you don't click it and get the green check mark?
He did a great job.
You're gonna be responsible no matter what.
Their name's on it.
Your team is on it, they saw you last,
Yeah.
you knew they were on these meds. There's no getting around the liability of it. It's more of just a patient safety check to put it in your face of, hey, here's all these medicines you might want to actually pay attention to before you send this person out of here and take on the liability.
Right. Okay.
All right, so looking at risk here, we got,
30 days.
what would you just off the cuff put as the risk level on that?
Even though the prescriptions are over the counter availability.
Anybody already do anything different?
Whatever the 3 is, whatever that is. Whatever that is.
So yeah, there's a prescription for cetirizine, but it's a level 3 because it's over the counter med. Prescription for fluticasone, level 3 because it's over the counter med.
If they add Salon with their prescription, then we go for
You do what?
the Salon.
Tesla pearls? Yes.
See?
Yeah, so that's like, how could this be a level 4?
Yes.
You prescribe Tesla pearls, which can't be gotten over the counter.
The prescription.
Suddenly you now
That's why I
get
always-
prescription drug management and you got a
I
level
have
4.
it.
One benzodal for anxiety.
So I threw in, I put a Tesla and I went with ibuprofen, like, if they got nasal congestion, like ibuprofen nasal spray, I don't believe it's over the counter yet. So it's still, you got a prescription drug, now you got level 4 on this piece.
I always took the Salon products for all those things. Level 4, buddy.
Still gets paid by the hour.
All right, so now, I mean, this is kind of getting real theoretical about this. All right, but let's say this patient's flu positive.
Wouldn't change that.
I mean,
You
to
They're out of the
change,
window for 3 days, right?
I mean,
Hopefully. But if they were in the window, you just hopefully.
So do you even have, so that becomes the question, do you even have to prescribe it to get credit for it?
I think you just mentioned it, to discuss it with the family, it will be account with you. But if you say like, this is what we have to give, but I think you are out of the window, so you'll not benefit from that. Just by mentioning that is enough. I
Yeah,
think.
that's prescription drug man.
I guess I could do test on pearls, but I'm not going to. Room. Yeah, I'm talking about it.
Yes.
Okay.
I think, yeah, that's one of those, I don't know if your coder would really.
Discuss Tesla pearls, refuse to give.
Yeah.
But,
Out in the hall.
but I mean, how often do you see these patients who test positive for the flu? They either want Tamiflu or Zofluza, but they don't meet CDC requirements to be high risk for it. They don't need it, or they're out of the window. You have that whole discussion, but you're not getting credit for it unless you have a nice little
So when they
auto
come
text
in,
that says that.
when they come in and want their self-trax on the steroids, you say, if they ask for it, we're not gonna give it. I get credit for that.
Yeah.
Oh,
You consider a treatment plan.
But
See,
they
I
recommend it.
always, but see, I always document that stuff because from a coding standpoint, it's great. And from a complaint standpoint, it's even great.
Okay.
Cause if they call and complain or fill out a survey and complain about you, you've addressed it in your note as to they brought this up. I talked to them. I said they didn't need it for these reasons.
That's good.
Plus, it also covers you, if they're already not happy about getting something that they wanted, and then they turn out to have pneumonia or COPD exacerbation that they didn't have when you saw them, but it blew up 2 or 3 days later, and now they're blaming you for not taking care of them.
Yeah.
Like, it just,
I see that. Okay.
like, I document it to cover that aspect of it, but it's actually getting you level 4 credit because you're addressing prescription drugs. Whether you're giving it or not, it doesn't change your medical decision-making process as to whether you give it or not.
So this note, if he wrote, will not,
He or she.
he or she said strep is negative, no indication for amoxicillin, prescription management. He got to level 4, without even discussing test on pearls or anything.
Maybe. I mean, I guess that's getting into, you're now
Hypothetical.
hypothetical diagnosis with a hypothetical prescription. It's too many, it's like Inception. You got too many layers deep.
I mean, if they have a carrier of strep and you know it's a carrier and it came positive and you discuss with them, hey, we know it looks like it's more carrier status. You don't need antibiotic at this moment. That's a management here. Yes.
I agree. If the test indicates a possible treatment and you're choosing not to do it, that's probably more likely to get you
Credit.
true level 4 credit than saying, well, you might have had this and tested negative and I might have prescribed you
What if
that.
you say,
but I didn't.
if cultures are positive, we'll prescribe antibiotics?
I think if you're going to the point of getting a throat culture because you're expecting it, I think you should be ready for that.
Okay.
Because you've outlined a medical decision plan that gets you to a level 4.
Okay.
Whether all coders would give you that or not, I would argue. I'd contest.
Could have seen 2 level 3s by the time we finished.
But you're probably gonna put that, but if you order the throat culture,
Yeah.
you're gonna put that in there.
Yeah.
So you just make sure you got those habits of putting those things that actually. I mean, because how quickly can you say, if you're gonna put into your assessment plan, throat culture ordered,
Yeah.
how much longer does it take to say throat culture ordered, comma, will prescribe amoxicillin if positive? I mean,
Unless
you're
it's-
talking
Unless
seconds,
it's
seconds,
ratio.
unless it's serration, and now you got a conundrum, level 5.
Huge.
3, 4, 5.
Don't step in that trap. All right, so from a summary standpoint, diagnosis
3,
3,
4.
data 4, risk 3.
We
it's
still,
gonna be
we still have
another
3.
3.
Which is exactly what it should be.
I agree. Unless you get the pearls, maybe a 4.
Okay, we didn't.
Yeah, had you prescribed, had whoever did this prescribed ibuprofen,
That's exactly. Come on.
could have gotten level 4. Which, if they were working for RVU, would have made them an extra 48% in RVU.
if we made that.
That's a big deal.
Can't said person go back and addend their no.
RVU
If you're, if you're working in an RVU model,
revenue, yeah, whatever. What the stands for, RVU.
relative value,
Relative
relative
value.
value. It's work related. Relative value, yes. But yes, so the extra 0.62 RVUs, not insignificant when you start getting into how many of these you can see.
Level 4, which is 219, 214.
Like we're out of time.
Instead of pay. to the-
Questions have been addressed.
That makes sense.
See you later.
On business, it will be a beneficial.